You have everyone for your team here that you need?
Yes, I believe we do.
Okay. Mr. Miller, are you all set?
Oh, and I'm handling the hearing today. Karen Tyler, Associate General Counsel.
Hi, Ms. Tyler. How are you?
Fine, thank you. How are you?
Well, when you say you're handling, what do you mean?
Well, I'm representing CVMC.
Okay. Right. So I'll call the meeting to order then, and I'll turn it to you, Ms. Tyler, and I'll have Mr. Hanksler, our counsel, swear in any witnesses that are testifying. And what we'll do is we'll have you give your presentation, and then our staff will give a presentation. We'll have a legal overview, and then the board will ask questions of the witnesses. I'm sorry, Ms. Corlman will actually swear in the witnesses. Okay, great. Mr. Miller, we can go on the record.
Okay, we're on the record.
All right, good morning. Today is August 20th, and we have the CVMC fiscal year 24 potential enforcement and request for a budget adjustment. We've noticed a potential vote, and I'll have Ms. Corlman swear in the witnesses for CVMC.
Hi, everyone. So if I can have everyone who's being sworn in, please raise their right hand. I will give the oath, and then if everyone could individually, when they say I do, say your name for the court reporter, and then say I do individually. So do you affirm that the evidence you shall give relative to the cause now under consideration shall be the whole truth and nothing but the truth under the pains and penalties of perjury?
Anna Noonan, I do.
Kim Patnode, I do.
Rick Vincent, I do.
All right, is that everyone?
Yes.
All right, you're sworn in. Thank you.
Would you like me to go ahead and start, Chair Foster?
Please.
Thank you. Well, good morning. Again, I want to thank Chair Foster and members of the Green Mountain Care Board for the opportunity to meet with you today. Today's presentation, coupled with our FY26 budget submission and the FY25 mid-year adjustment proposal that we discussed on August 8th, reflect our deep commitment to balancing affordability while ensuring quality and access to the vital healthcare services that Central Vermonters need. Central Vermont Medical Center remains committed to our efforts to continuously improve quality, maximize the efficiency of our operations, expand access, and advance partnerships across our state to address healthcare affordability. Our margin in FY24 was driven primarily by unanticipated increases in utilization by patients who required the care we provided. Most of the unbudgeted NPR was derived from care provided to Medicare patients, that was approximately $10.4 million, and Medicaid patients, $6.1 million. In FY24, CVMC achieved a positive margin of 1.7%, our first in 8 years. This positive margin followed 7 consecutive years of negative operating margins, ranging between a negative 0.6% to a negative 6.5%. Fiscal year to date, CVMC has a slightly favorable positive margin of $296,000 through June. It's critical that CVMC remain financially stable so we can continue to provide the vital care and services our community relies on. In FY24, we cared for more Vermonters than we had in previous years. Included in those volumes are patients that we accept into our ICU and acute care units from outlying hospitals. 9 out of 14 Vermont hospitals transferred patients to CVMC in 2024. In the past, those patients likely would have been transferred to UVMMC. Taking care of these patients here opens capacity at UVMMC for higher acuity, tertiary care that only they can provide in our state. Most of our unbudgeted NPR in 24 was used to cover expenses to provide that care to our patients. Today, CVMC respectfully asks the board to adjust its FY24 budget in the full amount of the hospital's $23.7 million NPR budget variance and rebase CVMC's budget accordingly. Should the board elect not to adjust or rebase our budget, I ask the board to permit the hospital to retain the $23.7 million overage and request that it not take enforcement action. I'll now introduce Kim Patnode, CVMC CFO. who will highlight additional information in support of our request. Kim?
Thank you, Anna. Jen, do you have our slide deck ready?
I do. Let me pull it up.
Thank you. We can go ahead and start to slide 3. Thank you. Thank you, Chair Foster and members of the board, as well as the staff. I know that this is a lot of work when you have to go back through our notes and our reports that we submit to you. This slide is a summary that summarizes the 25 net patient revenue bridge report, which is a report we do submit to the Green Mountain Care Board that summarizes the $23.7 million, which is 8.6% average of our net patient revenue variance between actual results and the budget by payer. I'd like to focus on 4 points on this table. The first is in the total section of our bridge report, Medicare and Medicaid account for 70% of our total NPR overage for a total combined of about $16.1 million. Major commercial insurance payers, which are considered Blue Cross, Cigna, and MVP, are about 5.8% of the total variance, and that's about $6.5 million. Secondly, of the $23.7 million NPR variance, utilization is the largest driver of this variance at $20.1 million, or 85% of the NPR overage. Of the $20.1 million utilization variance, 10.7 or 53% of that utilization variance is from our major commercial payers. Thirdly, when we look at the impact of collection rates compared to budget for an NPR overage, which is about 6.5 million or 25% of the total NPR variance, major commercial payers are showing an unfavorable budget and collection rates of $4.6 million variance, while Medicare and Medicaid are showing favorable variances. Please keep in mind when we do our budgets, we do not have the final rulings for our government payers as we submit our budgets on July 1st. We do a preliminary projection for those government payers based on preliminary informations, and at the end of the day, our government payers are not negotiable. In addition, within the Medicaid overage of the $4.3 million, Woodridge Rehabilitation and Nursing Facility received approximately $1.6 million from a fund called the Extraordinary Financial Relief Fund Program that is unique for our nursing homes to help offset the high costs of the travelers we were using to keep our patient residents in nursing homes and at a lower cost of care than an acute care setting. Commercial payers were estimated at the time to have a collection rate of 74.5% at time of budget. And at the end of the fiscal year, with a collection rate for major commercial payers, we ended at 72.8%. That is about a $4.2 million unfavorable budget variance for our commercial payers. Lastly, just as a reminder, our payer mix seems to be the strongest in not having a lot of movement. That's about a $1.1 million overall percent per dollars of our net inpatient revenues. And you can see the largest shifts were from Medicaid and self-pay other categories to Medicare and major commercial. This was the time period we were anticipating more patients moving from Medicaid to commercial payers as the post-COVID Medicaid provisions had been ending. On our next slide, we talk about, and I emphasize, the unavoidable and anticipated increases in our patient volumes. When we compare fiscal year 24 to fiscal year 23, CVMC cared for about 1.2% more patients seeking care at our facility, whether it was in our inpatient, outpatient, or our clinic settings. When we filter the total of those 731 patients by location, CVMC cared for more Vermont patients, 1.5% more at 910 new patients coming to the CVMC site, and less New York and out-of-network patients by about 6%. We also filtered the types of those unique patients by the services they were requiring between inpatient, outpatient, and professional, or been calling our clinics. I want to take a note that the differences between what we have showing in the top half of our graph versus the bottom half graph do not line up equally. Keep in mind, a patient who comes into a clinic may have an encounter in our clinic, may also have subsequent tests being ordered that would show up in our outpatient settings. This is about approximate increase of our NPR, about $3.3 million when all said and done, of new patients seeking care at CVMC. Moving on to our next slide. As noted on the slide, there's four basic categories that I would say that are tied to our NP are out of our control. One is pharmaceuticals and GI services, and the unbudgeted impact to Woodridge Rehabilitation and Nursing Services for extraordinary financial relief funds. Then lastly, the other pieces that we are unable, as a reminder, to renegotiate contracts or rates with our government payers. And I just wanted to remind everyone that CVMC is a sole community hospital provider with Medicare, which does help in our Medicare reimbursements, but does not completely cover 100% of costs for Medicare patients. We would be remiss to only talk about net patient revenues if we didn't talk about the expenses that increased utilization caused us to incur. Since much of the NPR variances of the 23.7 is tied to utilization, we did, as Anna noted, incur additional expenses between supplies and staffing. This slide summarizes the major categories of budget variances, costs of about $17.2 million, which is a 5.8% increase over our budget between labor and non-labor. And lastly, as Anna noted in our opening remarks, we did end the fiscal year with a positive margin of $5.5 million, the first in many years. That's about a 1.7% net operating margin. We originally had projected to lose $2.8 million. If we remove the two material one-time adjustments, the Woodridge Rehabilitation and Nursing Facility Extraordinary Relief Funds from net patient revenues, and from our other revenues, the employee retention credit that we had accrued for the calendar year 2020, we would have been left with a $1.9 million favorable bottom line, which is just barely at 0.6 of a net operating margin. We know that our facilities are old. We know that we need to have cash. On the bottom section of this slide, I've highlighted two metrics on the bottom. Days cash on hand. You can see we stay steadily in the 76-day range for our days cash on hand, and compared to metrics as designed by S&P standards, we are way below where we should be. The other piece is we need cash, we need a net margin to reinvest in our buildings. And I also highlighted this section as well. Our age of our building is at 20 years. That is extremely beyond where we are needing to be to make sure that we keep our facility in operational manner to take care of our patients. Anna, I'll turn it back over to you for closing.
Thanks, Kim. So again, in closing, CVMC respectfully asks the board to adjust its FY24 budget in the full amount of the hospital's $23.7 million NPR budget variance and rebase CVMC's budget accordingly. If the board elects not to adjust and rebase the CVMC budget, CVMC asks the board to permit the hospital to retain the $23.7 million NPR overage and requests that it not take enforcement action. Again, thank you for your time and your consideration, and we're very happy to answer any questions when you're ready.
Thank you all very much for the presentation and overview. It was helpful. I'll turn to Mr. Sutter.
Chair Foster, would you like us to do our staff presentation now, or
yes, please.
Great. Great, thank you. We have a short presentation to just provide some an introduction again to the topic today. Our Julia from our legal team is going to review statute, rule, and policy briefly, and then I'll summarize the request. CVMC basically covered most of the material we're going to cover as well, but just provide a quick summary of their request, and then provide staff recommendations around the budget adjustment and the potential enforcement options. So we will discuss their request to modify their FY24 NPR cap equivalent to the overage for the year, and then we'll also discuss the Green Mountain Care Board's potential enforcement of that overage. And I will pass it to Julia to go over statute, rule, and policy.
Hi, everyone. Julia Corlman, staff attorney. So I'm just going to walk us through the statute, rule, and policy that we have. So these, there's both the overage enforcement, but also the hospital's request to adjust their budget. And so these will touch on both of those. So first, we're going to start with 18 VSA 9456. This is the hospital budget review statute. It shows the standard that the board's going to look at when a hospital submits a budget adjustment request. This section states that the board can adjust the budget upon a showing of need based on exceptional or unforeseen circumstances. If we then turn to our rule, we have Green Mountain Care Board Rule 3.401 in subsection A. This rule outlines the factors that the board takes into consideration when considering a budget adjustment request from the hospital, whether to approve or deny that request, or considering if they're going to take overage enforcement. These factors can include the variability of the hospital's actual revenues, the hospital's ability to limit services to meet its budget, the financial position of the hospital in relation to other hospitals and the healthcare system as a whole, the hospital's performance under budgets for the previous 3 years and its projections for the next 3 years, as well as any other considerations that the board deems necessary. If we look at that same rule, but the next subsection, there's language there that requires the board to determine that the hospital's performance has varied substantially from its budget after they conduct a review of those factors listed above. And then last, we can turn to the policy on budget amendments and adjustments. This policy has language that allows the hospital to request a budget amendment to account for unanticipated changes to their approved budget. All right, I'll turn it back to Matt.
Thanks, Julia. So very quickly, just to recap, I think we already discussed this, but on the right, you'll see a table showing CVMC's historical performance, NPR against budget, and the FY24 variance we're discussing today. So they exceeded their budget NPR by 23.7 million, or an 8.6% variance, which is above the threshold for enforcement of plus or minus 1%. They're requesting their FY24 NPR cap be adjusted by their total budget to actual variance, and they're attempting to justify that adjustment due to the variance resulting from unavoidable increased volume, revenues outside of their control, and the general financial position of the hospital, as Cam and Anna outlined. So they're reading through some of their justifications. As they mentioned, there's a 1.5% increase among Vermonters in patient volume. I will note that that's comparing it to FY23 actuals to FY24 actuals rather than a budget to actual comparison. But they did make that case. And I did want to highlight that they attribute 19 million of the overage to utilization. And after accounting for costs, that generates approximately another $5.2 million in margin. They also mentioned, again, that utilization variance was driven in large part by higher radiology volumes, particularly CT scans. They did attribute in their letter to us this to partially to becoming a certification of the primary stroke center, and there was a subsequent increase in patients requiring CTs for diagnosis, but we didn't receive specific quantification of how much that is. I will also note that the FY23 budget or FY24 budgeted CT scans were significantly below the FY23 actuals. So there was a budgeted decrease that didn't come to fruition there. They also mentioned a few other sources outside of their control. There was 400,000 associated with Green Mountain gastroenterology volume increases, a low volume adjustment in their Medicare cost report. They noted the 4.7 million in increased pharmaceutical revenue, and then their inability to negotiate prices with public payers. So they also noted their financial position weighs in favor of budget adjustment. They highlighted this was their first year with a positive margin since FY16. They're relatively low days cash on hand, and a couple other items that might be having the appearance of inflating their operating margin. So that's there's the extraordinary financial relief at Woodridge, which is showing up as 1.6 million on the NPR, and then another 2 million in other operating revenue for employee retention credits. So again, they presented this. This was just their bridges document. We just wanted to include it here for reference, but I think Kim already walked through it. But you can see the total utilization variances on the actually, where's my highlighter? Over here, you can see the individual total variances by payer down at the bottom. So staff's recommendation about the budget adjustment is the staff does not recommend approving their request. We don't think they've shown that their request for adjustment is based on exceptional or unforeseen circumstances, and they have not adequately justified their request to have the budget adjusted by the full amount of the overage, or 23.7 million. I do want to note that some of the explanations they provided for the overage may be sound. So, for example, they did note the total NPR overage, as I mentioned before, includes 1.6 million in financial relief related to prior year events. I think that's correct in not considering that, even though it rolls up to NPR and like flows through to their operating margin. I think they generally have a case that shouldn't be considered part of NPR for enforcement purposes. But I do think it's more appropriate to consider those individual drivers of their significant NPR overage during enforcement rather than adjusting their budget so it exactly equals the actuals. So staff recommends reviewing CVMC's justifications for their FY24 NPR overages when considering potential enforcement, but staff does not recommend holding a vote today or delaying a vote until a later date, providing time for any post-hearing questions or follow-up. I will add, should the board choose to enforce CVMC's overage by targeting commercial revenue, staff would recommend the following approach, which would be to issue a separate budget order modifying the eventual, as we discussed during the budget hearings, the expected FY26 commercial NPR caps by an equivalent reduction, and then require CVMC to provide documentation to the board about how it will effectuate that decrease by changes to its commercial rate. So now we just have a couple slides with potential motion language that we could review if you would like, Chair Foster, or I can pass it back to you.
Thank you. Why don't we go to board questions? You can leave this up for now. Actually, I just want to read it while we go through board questions. I'll start with Member Walsh. Do you have any questions?
Yeah, just a few. Good morning, Chair. Thank you. Good morning, Matt, and good morning, everyone from CVMC. Thanks for the presentations. What I'm looking for with the presentation is help understanding not just what happened, but why, and what were the leadership and management choices that surrounded that. So we saw that gastroenterology, pharmacy, rehab, CT scans all rose substantially. And I'm wondering, when you saw these trends developing, what choices did you make? Did you choose to change anything, adjust anything, or choose to let them continue?
So I'll start with that, Member Walsh. Obviously our mission is to serve our community. So when we saw volumes increasing, we knew there was likely pent-up demand for the services that we were seeing increased volumes in. So we chose to service those volumes, service those patients in our community. And as I mentioned, we also chose to accept transfers in from outlying hospitals. So 9 out of 14 hospitals in that year began sending transfers into us. We thought that made sense for us to take them here. We had the capacity to take them versus having them transferred to UVMMC, which is a further distance for those individuals' families to travel. But also, again, we had the capacity and would leave UVMMC to have the capacity to take the tertiary care. So although we monitored those volumes, we thought we were in alignment with our mission to provide the services for patients that required that care.
Did you at any time consider reducing services elsewhere or reducing prices to stay within your budget?
At that time, we did not.
You mentioned that you felt that this was part of the mission. How, if we were to consider this a success story, how would you link it to state health reform efforts? Those
So-
efforts, those efforts prioritize affordability and moving care out of hospitals.
Right. I think for the type of services we were providing, the care unfortunately was not able to be sent outside of an acute care setting by and large, and that the volumes were primarily for services that we provide that are located within the acute care setting or within the hospital. I think what we would do differently in the future, and I think we've demonstrated that in our hearing on August 6th, is if we see those volumes increasing as we did this year, that we would enact a mid-year rate increase, which we did do in this fiscal year. So I think good lesson learned for us in that regard. So I think that would be the action we would take and did take this year and would take in the future.
So I appreciate that. I wanted to ask actually, so I'll jump to it now. Have you made plans for the future? It sounds like the future plan is if overages are noted, it's to come back before us and request an increase in the budget as opposed to trying to make any other adjustments to stay within the budget.
I'm sorry, Member Walsh, you cut out during your statement. Could you repeat that?
Sure. So I wanted to ask, you brought it up, I wanted to ask lessons learned and looking forward, if you'd put in any new systems or processes to identify overages or budget variances earlier. And it sounds like you have, and it sounds like the plan, if you're running hot, is to request a mid-year increase. And I'm wondering if there'd been any consideration to do anything other than ask for an increase. For example, reducing prices elsewhere or modifying utilization elsewhere. Anything from a management leadership standpoint to operate within the budget.
Yeah, I think what we do today and what we would continue to do moving forward is monitor our operating budget overall, seeing where the volumes or services are increasing, try to make adjustments where we can. I think the challenge is in making adjustments when it involves direct patient care and services. So I think that we would continue to be vigilant in that regard. We do, obviously, as you are well aware, submit monthly reports to the Green Mountain Care Board. I think that what would change going forward is more interaction with the Green Mountain Care Board outside of those monthly reports that we provide today that demonstrate a higher utilization. But as far as making adjustments, those are difficult to make. Pardon me, on a month-to-month perspective, we look at those trends over time. Some of our overage in 24, as we mentioned, is from a private practice that utilizes our services here, Green Mountain Gastroenterology. That's a service that we support them in providing to our community. I think the board is very well aware that we have an aging demographic in Central Vermont. And so some of these services we believe are coming from that aging demographic and the need for more of these types of services.
So a pent-up demand for CT scans is the big driver in the Barry Berlin area.
It demonstrated itself, yes, in 24.
The community health needs assessment identifies mental health care and substance use disorder. There, is there any linkage with your budget and trying to address those community needs?
Absolutely. So for many years, substance use and mental health have been identified as issues within Central Vermont. And we've identified a number of initiatives and supported a number of initiatives with our community partners, specifically the Central Vermont Prevention Coalition, which is an organization that CVMC launched to address the substance use issues in particular. We also have a HRSA grant that's enabling us to provide some innovative practices to our community. Pretty robust work, and some of that work is being translated at a national level. In fact, one of our providers that leads that effort was recognized nationally for those efforts in the substance use arena. In the area of mental health, we have strong partnerships with Washington County Mental Health, both in our acute care and our ED setting, and in the community services that they provide. And we are actively engaged in working with them to see, and the Department of Mental Health, to see if we can stand up a more robust mental health urgent care center, which again would keep the care in the community at a lower cost, which I think would be in alignment with the healthcare reform objectives.
Thank you. That's helpful. My last question is kind of an internal within CVMC, but also the health network. As you saw these overages beginning, were there any discussions with the CVMC board about what to do?
There were not. We share more the trends that we were experiencing related to increased utilization for the reasons we've already mentioned. But we did not specifically ask the board for guidance on how to address it. I think given the learnings we've had this fiscal year to date, that we would potentially engage them differently in that way. As mentioned, we would also probably engage differently.
Now, Ms. Noonan, you cut out for me. I don't know if that happened for anybody else. Is anybody else having difficulty? Or is it just me?
Tom, this is Owen. Can you hear me okay?
I can hear you. Yeah.
I'm generally fine. I'm getting a little bit of breakup here and there, but not significant.
Okay. Okay. I think I got enough. I heard enough, Ms. Noonan, of what you were saying to get a sense of your answer. So thank you very much for answering my questions and presenting this morning.
Thank you.
Member Teachout?
Good morning. I have a couple questions I wanted to ask. One is on page 4 of the response that you sent to the board, dated July 30th. Page 4, there's a middle paragraph that begins with the word third, where you're talking about your inability to negotiate with government payers, and you give a lot of information about the rates that Medicare is paying you. Are you saying that Medicare is paying more than you anticipated? A little explanation would be helpful for me.
I can take that. When we put our budgets together, we don't have the final rulings from Medicare or Medicaid. We have preliminary rulings, and oftentimes inpatient becomes final after we submit our budgets on July 1st, and the outpatient increases definitely do not come final until more toward the fall, the August time period, because that's when the outpatient outpatient rates become final for Medicare. What we were trying to demonstrate is that Medicare and Medicaid, because they use cost reports, data that's 2 years often older to set rates and adjustments, that we don't have the ability to have a quick turnaround in rate adjustments. So like the years that we had higher costs in our labor for using travelers during the COVID era, or the pandemic era, I call it, the costs weren't caught up. Does that make sense?
A little bit, and I'm just not sure why, if you get the final numbers in August, they can't be updated in your budget, that we, the Green Mountain Care Board had not yet decided.
We have offered in previous budget years to adjust our budgets when they are finalized. I do not recall if we had done that in 24 or not.
Okay. Thank you for that explanation. My next question is on the certification for the primary stroke center or the stroke clinic. Did you include increases in CT and other imaging because you were anticipating that as a requirement of meeting your certification?
Member Teachout, we did not. Normally, the certification timeframe for receiving that certification is more lagged, and we received ours relatively quickly. And so we did not anticipate that we would receive that certification as quickly as we did. So therefore, the budget submitted did not include those increased volumes.
Okay. And then my last question is on how you attributed expenses to the increase in utilization. It was in one of your slides. What is your methodology for doing that?
You want to handle that one?
Yeah, thank you. Great question. Thank you. Basically, additional volumes do reach points where we have to add staff and or supply costs. So if you increase your volumes by what we did at 2024, you're assuming that the costs of, or you're experiencing costs and supplies and people really is the two areas. And we're just using our cost accounting system to assign those costs.
So just to follow up a little bit, are you seeing efficiencies at some point with increasing utilization?
Not every patient, with the exception of supplies, because we don't use supplies, would incur or cause us to increase staffing. So we do have areas of plateau where we can accept one more patient, two more patients before we have to increase our staffing. But by and large, our supplies are 1 for 1, our drug costs are 1 for 1. So every new patient that comes in, if they're experiencing or hearing and needing pharmaceuticals for, say, chemotherapy, that will increase the costs.
Okay, great. Thank you. It was very helpful. That's all the questions I had.
Thank you.
Member Holmes?
Great, thank you, and good morning to everybody. So thanks for the presentation. I do have some questions here. One was your letter to the board to justify the request for the budget adjustment states that NPR volume unavoidably resulted from increased patient volume. Did you do any analysis to determine how much of the increased utilization was truly unavoidable?
So Member Holmes, I would say that we don't have a tool that's refined enough to look at unavoidable utilization. We do spend time looking at volume trends, and I think the board is aware of some of the efforts we're trying to do, put in place to reduce our emergency department volumes by seeing those patients in our primary care practices. But as far as looking across the board to see what of this is quote unquote unavoidable, it's challenging to do a refined analysis of that. The fact is that, you know, people come to our organization to receive the care. So we sometimes budget correctly for that. And this year we were not able to do that as successfully as we might have in the past.
Okay. In your opening, you talked about patients being transferred to CVMC for inpatient care.
Right.
On page 3 of the letter, the response, you broke out, or somebody from your team broke out utilization variance by cost centers. And under hospital, I would have expected then to see some significant deviation in inpatient admissions from transfers. All I'm seeing is 15 unbudgeted births on the hospital side. Is there additional data to support your statement that it's your inpatient admissions in 24 varied substantially from your budget?
We can provide additional analysis on that, Member Holmes. I do not have those numbers right in front of me.
Okay, thank you.
Because keep in mind at the same time, Member Holmes, at this time, we were also doing a lot of work in length of stay, getting the right patient to the right level of care as well. So if I will have to pull that data, but I think some of our length of stay improvements actually did not show all of these transfers one for one as increased patients because we were doing such good work with our length of stay efforts.
I'm just trying to understand the variances. And so on net, it doesn't appear in the data that you provided that on net inpatient admissions is a cause of the variance from what you've provided so far. So it'd be helpful to see additional information on that. You also referenced this certification as a primary stroke center as driver of some of this increased utilization. And in particular, the letter stated that as a primary stroke center, CVMC is seeing an increase in patients presenting to the ED with stroke symptoms. It looks like you received the certification in August 2024. So to support that statement, do you have data that shows the number of ED visits of patients presenting with stroke symptoms going up, and also the number of CT scans for potential stroke, even by month for 2024, to show that once you got the certification, you saw an uptick, as you said, in both patients presenting and the number of CTs ordered?
We can provide that information for you, Member Holmes, but I also want to share that we had in addition to the volume associated with CT scans, we had related to stroke, we had a volume increase in CT scans of about 12% in fiscal year 24. And out of that 12%, 56% of that was in the ED. So there were definitely increases in head CT scans, but there were increases in CT scans in general as well. And that was not reflected in our letter to the board on July 30th.
Okay. Yeah, it does seem like $6.8 million of the utilization variance was driven by radiology. So I wanted to ask a few questions about that. Between fiscal year 23 and fiscal year 24, how much did you increase commercial rates for CT scans, MRIs, and ultrasounds?
Member Holmes, I'll have to get that information for you.
Okay.
I don't have that at my fingertips.
And this also maybe follow up, but did you apply higher than GMCB approved commercial rate increases to any of the CPT codes in those imaging departments in fiscal year 24? In terms of rate allocation, specifically, how did you apply the GMCB board approved commercial rate increase specifically to the radiology CPT codes?
Again, I'll have to get that to you as follow-up.
Okay, thank you. And your letter also talked about $4.7 million, and I think you referenced it in your slides as well, in unbudgeted pharmaceutical revenue. And the letter referenced significant expenses associated with pharmaceuticals. I think you whipped by it really fast, but on slide 6, I think I saw unbudgeted pharmaceutical expenses of $3.7 million. Is that correct? Maybe you could pull it up. I think it was on slide 6.
Jen, can you pull that up for Member Holmes? It is slide 6. In our letter, we also included a listing of the high-cost drugs that we are using in our chemotherapy space. And that's where we're seeing the largest increases and largest uses.
Okay, so I'm just trying to map out. So I was going to ask you directly what the margin was associated with that unbudgeted pharmaceutical revenue, but I'm thinking it may be right here. So it looked like 4.7 million in unbudgeted pharmaceutical revenue, and here it looks like unbudgeted pharmaceutical cost was 3.7. So does that mean that you generated an unexpected $1 million in pharmaceuticals? Is this mapping?
I would have to get you the details because you also have staff that are involved in compounding those drugs. that would not be in the total cost of what that drug is. That's pure drug cost. So we
Okay,
can get
well,
that
helpful
follow-up
to
too.
understand that.
Yep.
Yep, and on the table with actually the total utilization variance, where you do have a column estimated cost tied to utilization variance, it would be helpful then there to see the pharmaceutical broken out separately. But I did want to ask you about that column where it says estimated cost tied to utilization variance. Does that estimated cost include both direct and indirect costs, or is it direct costs only?
I will need to confirm with my reporting to verify if it's indirect only or direct, or it does include indirect.
Okay, that would be helpful. Thank you.
Mhm.
And my last question is, what actually triggers eligibility for the low value adjustment by Medicare? I know that was referenced as a source of some of the revenue. What actually triggers eligibility for that?
I have been out of the cost reporting world long enough to be very detailed in how we apply for that. It does use our cost reports to identify. So in fiscal 23, we would have used fiscal year 23 cost report to look to see if we could apply for those low volume or low adjustments. It is usually a year in arrears. And since, if I remember, and I'll have to check with Amy, my colleague Amy Vaughn, who is my cost report guru, whether or not I believe that program has ended for us and we no longer are going to have that option. So we do look at that. We look at all resources from our government payers to make sure we're maximizing those reimbursements. Keep in mind also, our commercial payers are only about 200% above what we're getting from Medicare now. So we're probably more closely aligned to what we get paid with Medicare to what we have for commercial payers, because we are a sole community hospital. So that does help bridge the gap and close that reliance on some of the commercial rate increases.
Okay. You mentioned that you apply for it. When do you typically apply for the low volume adjustment?
Typically, it's after a cost report is finalized and submitted. And I will have to confirm again with our cost report gurus if we have to wait for the cost report to be settled or if we can file the ask on a filed cost report. Because like
maybe it'd just be
else,
helpful to know when you actually applied for it for fiscal year 24. I know it said that you were approved in September of 24. So it'd be helpful to understand when you applied for it. And also generally the probability that hospitals who apply, who are eligible, receive it. So
we will take care of that as a follow-up. Thank you.
Thank you. I think that's all I have. Thank you so much. I will turn it back to Chair Foster.
Thank you.
Thank you. Just a couple on Member Holmes's question. If you could actually give us a chronology or timeline of the applications and the communications relating to some of the points you're identifying as causing the overages, so including the Extraordinary Relief Fund, the Employee Retention Credit, the low volume adjustment, and the stroke center certification. And the reason I'm asking that is I'm trying to understand the standard we have to apply is unforeseen and unexpected circumstances. And so we'd like to see the chronology of this to understand that. And that's my first question. What is unforeseen and unexpected?
Well, I would define it, and this not a legal interpretation, but my own definition would be something that we hadn't anticipated, and in this context, something that we didn't budget for.
And what was it that was unanticipated?
I would say the increased volume that we absorbed in fiscal year 24. The level of utilization of the services was unanticipated.
And can you, I mean, to me, it seems like it would be something you could anticipate. If you got this certification and then there's more transfers coming, that seems like something you maybe could anticipate.
Again, as mentioned earlier, we did not think we would receive those volumes in fiscal year 24 or even in partially in 25 because of the usual timeframe that we've understood it takes to receive that level of certification. So we received it more quickly than anticipated. So some of those volumes hit in 24 and unrelated to our conversation today, and some of those volumes were in 25 and weren't completely budgeted there either.
And the increased volume due to the stroke center, you may have provided this, I apologize if I missed it, but what was the breakdown between increased volume due to transfers and just increased volume due to your local market?
So transfers in to CVMC in fiscal year 24, we had 127 transfers from 9 out of the 14 hospitals. Some of those were transfers back from UVMMC. So we're taking patients back that were transferred to UVMMC that live either in our catchment area or further south. And the other bulk of the transfers in were from Copley, Porter Next, NVRH, et cetera. So we have a tally of all the transfers in for fiscal year 24.
In terms of moving care out of hospitals to comply with caps, can you describe all efforts to move care out of CVMC to comply with the budget cap? I appreciated your answer to Member Walsh that this segment of patients was not movable. In your opinion, I understand that. I'm getting at the other lines of services. Can you describe the efforts to move other care out of the hospital to comply with the budget cap?
So I think our biggest focus area has been moving patients to our long-term care and rehab facility, a lower cost of care, but not a community-based, if you're thinking of that type of movement out. I don't think in 24 we were looking to move volumes outside of the acute care setting, as by and large those types of services were only being provided in the acute care setting. Does that answer your question, Chair Foster?
It might be more appropriate for a follow-up, but we'd like a description, or I'd like a description of all of the care that was moved out of the hospital in an effort to comply with the budget cap. So some examples may be you looked at the ED utilization, you found ED patients that would be better suited for treatment elsewhere. Maybe you increased your primary care hours, maybe you increased your primary care volumes, any of those types of things. And my question for today is just can you describe the discussions that you had relating specifically to this cap and what efforts the hospital would make to move appropriate care elsewhere?
Mm-hmm. Well, I would say that in an ongoing conversation for us is to look at, can we move volume to a lower cost of care? And I think that's demonstrated in CVMC's investment in our primary care practices. So we have a pretty large footprint of primary care, and we have looked at moving providers, and particularly in the back to the mental health space, into each of our primary care practices. So that work was planned in 24, but not actualized until 25. So those are some examples, but we're happy to get back to you with more detail if that's helpful.
Yeah, I appreciate that. And that's an important part of all of our reform goals. My question is very specific to this instance of the overage. Mm-hmm. Was there any discussions that you were part of, anyone here, relating to efforts to move care to comply with this budget cap? Not ongoing general, but hey, we're bumping up against the budget cap. We need to do something. I want to understand all of the efforts made specifically to comply with this cap.
No. I think we'd have to get back to you with more complete information in that way.
Are there any that come to mind as you sit here today?
I would say not to my knowledge specifically. I think we were more focused on addressing the pent-up demand that we're feeling, and our actions were more related to that issue. So in the radiology, we opened up Saturdays as an example to reduce the wait time. So we were more in the space of addressing access than trying to shift volumes outside to a lower cost of care, and that by and large, those lower costs of care, to my knowledge, did not exist from the standpoint of radiological studies, laboratory studies, those sorts of things, and acute care admissions.
I appreciate that. Thank you.
Yeah.
A couple questions. You pointed to the age of plant and the days cash on hand, which are something that we see in your budgets every year and are important for us to understand.
Mhm.
And they are not robustly strong. There's no question. But a couple questions. So the UVM Health Network has, I think it was around $300 million in unrestricted assets. How much of that $300 million at the network was seeded or attributed from CVMC?
So I can take that one, Hannah and Kim. Chair Foster, we're providing that response to you on Friday, so that was included in the list of questions related to the budget hearing. So we'll have those details for you by Friday.
Okay, great. I guess I very much appreciate that, but specific for Ms. Noonan or Ms. Patnode, do you know whether or not any of those assets at the network originally came from CVMC?
As we roll up as a system, yes, some of those dollars are counted in the overall health network days cash on hand numbers. If that's what you're asking for, Chair Foster.
Yeah, so my question is just if you know, so there's money there at the network, around 300-ish, give or take, in unrestricted assets. That money came from somewhere originally. And my question is whether or not the original source of any of that 300 million was CVMC.
The answer is yes. We should have for board designated funds, I believe in 2024, I'll have to get you the number, but I believe it was around 30 million, but I will get that detail for you and it will be provided to you again from the UVM Health Network on Friday. But I'll get it for 24.
Yeah, okay, great.
Mhm.
Can you describe any discussions you're having with the health network about utilizing some of those health network funds to improve your age of plant or days cash on hand?
Definitely during the capital process, we are pooling all of our resources together to be able to identify what our priorities are as a system to invest in our facilities. The challenge is, as you know, in many of our hospitals in the state of Vermont and even across the country, many of our hospitals are in very bad shape because we have been investing in our employees and not able to invest in capital as much as we had been in our employees.
Okay, so there are ongoing discussions relating to using some of those network assets to improve CVMC's days cash on hand and or your age of plant?
Not so much days cash on hand. I really like to stand on my own in that space and place. And Mr. Vincent can confirm that because we have an ongoing conversation of CVMC wanting to hold their own. But from the capital perspective, yes, there's investments that we are getting resources and help for. For example, the linear accelerator we just replaced, that was a CON. That is take care of our patients. And we are also looking at replacing an MRI that is probably very dated and beyond useful life that we will be replacing this fiscal year as well.
Great, thank you. In fiscal year 24, how much did CVMC contribute to paying for the network shared services?
We pay approximately 14%, between 13.5%, 14%.
Do you know roughly how many dollars that translates to?
If you give me 1 second, I actually have that. Better yet, rather than giving you the wrong answer, let me give that to you as a follow-up. I have too many spreadsheets open right now. I don't want to waste your time.
No problem. That's fine. Can you describe any and all discussions you had in fiscal year 24 about lowering the amount you have to pay for network shared services?
We did not. The formula that we use to have our allocation is a percentage of net patient revenues. And I believe we did have a couple of years that we did adjust that based on the overall performance rather than set it at budget time. We reviewed it at least once during the fiscal year to adjust.
Did CVMC consider paying less for shared services in an effort to comply with the board's budget caps for fiscal year 24?
We did not.
Could you have lowered the amount you paid for network shared services in an effort to comply with the budget caps?
I would have to defer to Mr. Vincent, but at the end of the day, the shared services is a total. So if we lower our cost, one of our other partner locations would have to increase their cost of care, of the shared service.
Or lower the shared service costs, correct?
Correct.
If you were able to lower the shared service costs that you have to pay for, couldn't you have lowered your prices in relation to the amount, the lower amount you're paying for shared services?
We would have to look at that independently because keep in mind, as I said, our commercial rates on average are only 200% above Medicare. And we know Medicare still does not cover our costs. I think the last time I saw, we were about 90% of our Medicare costs were being covered. So Medicare does not cover 100% of Medicare patients. Medicaid certainly isn't covering the cost of their patients.
Yep, understood.
Mm-hmm.
Okay, I think that's all I had. Thank you very much for being here and presenting this and answering our questions. I think it's really helpful. I'll turn to the healthcare advocate for any questions or comments.
Good morning, Mr. Chair. Mike Fisher here. I apologize, I'm off camera. Some technical difficulties. Briefly, thank you. Thank you, everyone, for your presentations, and thank you, board staff. The HCA does not dispute that CVMC gave more care and that more care to more patients and that Vermonters needed that care. But that doesn't pull us off our consistent message. I think that the HCA has been nothing but consistent on this question. Budget, we have a fear that budget orders lose their meaning if they're violated and are not enforced. Further, I guess if a hospital is receiving more revenue and is efficient, it should need less of a rate increase. So given those thoughts, we also want to recognize the good work that board staff did in its analysis, and we support the staff recommendation and recommend enforcement. Thank you, Mr. Chair.
Thank you, Mr. Fisher. I'll open up to public comment via raise the hand. Okay, seeing none. Personally, I think I'd rather wait on these potential votes, given that there's some important information that I think will help understand some of these issues. So I'm not going to make a motion. If any other board member feels differently, you're, of course, always welcome to. See heads nodding. So we'll wait for the information. And thank you very much, Ms. Noonan, Ms. Tyler, Ms. Patno, and Mr. Vincent for your information. And we'll be in touch shortly with some follow-up.
Thank you for your time.
Thank you. I think that's all we have on the CVMC hearing. Is there any other old or new business for the board? Okay. Hearing none, I move to adjourn.
Second.
All in favor, say aye.
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 Aye. And we are adjourned. Thank you.